The hip and pelvis are central biomechanical links in stability and postural control for the torso. Movement in the lumbopelvic region includes a combination of motion across joints in the lumbar spine, sacroiliac, and hip joints. Pelvic soft tissue disorders more commonly involve chronic biomechanical stresses from postural distortions rather than acute injury. The first 4 tests in this section evaluate the position of the pelvis and how that relates to various dysfunctions in the lumbopelvic region. The pelvis is composed of 2 halves. Each half is called an innominate. In movement, the innominates move both together and to a slight degree independently of each other. There are 3 important anatomical landmarks that are used in testing the position of the innominates or pelvis: the anterior superior iliac spine, or ASIS, the posterior superior iliac spine, or PSIS, and the superior edge of the iliac crest. In some people, it is difficult to identify these landmarks, but accurate identification of pelvic disorders requires you find these landmarks. Innominate rotation tests evaluate for the level of anterior or posterior tilt in the pelvis. While not considered highly accurate, these tests can be helpful in evaluating the contribution of postural dysfunction. For this test, begin with your client standing with the feet about shoulder width apart, and the client should be barefoot for this test to work appropriately. With one finger, locate the anterior superior iliac spine, and with the other finger, locate the posterior superior iliac spine. Notice the difference in height between these 2 locations. If the front side is a ½ inch or more below the back side, this is indicative of an anterior pelvic tilt. However, in some cases you may give a little bit more leeway with females due to the shape of the pelvis. If the back side is lower than the front side, this is indicative of a posterior pelvic tilt. A tight iliopsoas can contribute to an anterior pelvic tilt and exaggerated lumbar lordosis. The modified Thomas test evaluates for the presence of a tight iliopsoas or rectus femoris by measuring their relative length. Begin by having the client just barely sit on the edge of the table. Hold and brace the table in this position by placing your knee on it so the table does not have a tendency to buckle in the middle. Have the client reach up and grab a hold of the opposite leg and slowly help them back into this position rolled onto the table like this. You want to have the client's thigh at about 45-degree angle to the table. Once in this position, bend down to look at the length or the height of the other thigh that is extended off the end of the table. As long as it is below horizontal, the iliopsoas is at appropriate length. If it's higher than horizontal, like this would be indicative of tightness in the iliopsoas. You can also notice tightness in the rectus femoris. If the leg is dropping straight down, as it is here, the rectus femoris is also at good length. If the leg were extended like this would indicate tightness in the rectus femoris as well. The lateral pelvic tilt test assesses the level of lateral tilt in the pelvis by estimating the height of one ilium in relation to the other. Lateral tilt can be caused by structural disorders such as scoliosis or leg length discrepancy, as well as muscular imbalance such as tightness in the quadratus lumborum muscle on the same side. Begin with the client standing barefoot with feet approximately shoulder width apart. Locate the high point of the iliac crest on each side. Place your thumbs on that high point of the iliac crest, and then make a visual observation and compare the height of each side to the other. If one side is higher, for example, if this side were higher, this would indicate a right lateral tilt. The left side is higher, but the pelvis is tilting to the right. One cause of a lateral pelvic tilt is a difference in the length of the femur and tibia. The most accurate way to identify a structural problem is with an X-ray. When that's not available, the tape measure method is a good substitute. Take a flexible tape measure and place one end at the underside of the ASIS, or anterior superior iliac spine. Place the other end at the underside of the medial malleolus. Compare the length of the two sides, do the same measurement on the opposite side to see if there is a difference in the length of the bones. Even if there is a functional lateral pelvic tilt and functional leg length discrepancy, the length of the bones doesn't change and should be close to equal. Note that up to about 1.5 centimeters is considered within normal parameters to have a difference between the two sides. The supine to sit test evaluates tightness in the quadratus lumborum, which may be contributing to a lateral pelvic tilt. A tight quadratus lumborum may pull the ilium and lower extremity in a superior direction as the individual sits up. Begin by grabbing the ankles on each side and look at the level of the medial malleolus on each side. Have the client sit up and notice the position of the ankles as they sit up. If one ankle moves more superiorly than the other, there's a good chance there's tightness in the quadratus lumborum on that side. There are several nerves near the piriformis muscle that can be compressed. The piriformis can compress the sciatic, inferior gluteal, or posterior femoral cutaneous nerves against the sacrospinous ligament. Fibrous bands within the piriformis can also compress these nerves. The superior gluteal nerve can also be compressed by the piriformis against the greater sciatic notch. Most commonly, it is the sciatic nerve that is impinged, which can be mistaken for lumbar disc pathology. In this test, the piriformis muscle is stretched to assess whether there is pressure on the sciatic nerve when the muscle is pulled taut. With the client in a side-lying position, bring their hip up into full flexion. Have this hand hold the hip to keep it stable and push down towards the table to give a full adduction to the hip. This particular motion stretches the piriformis muscle. Ask the client if there's any reproduction of symptoms such as neurological sensations, pins and needles, or sharp pain down the back side of the thigh or down the back side of the leg when in this stretched position. In the PACE abduction test, the piriformis muscle is contracted rather than stretched to determine if pressure on the nerve increases. The piriformis muscle changes its action after about 60 degrees of hip flexion to become mostly an abductor of the hips. This test is performed with resisted hip abduction with the client in a seated position, which engages the piriformis in a contraction. Simply kneel in front of the client, place your hands on the outside of their thighs, and you will attempt to push inward as the client holds this position. This will engage the piriformis in a contraction. So Barb, hold that position there as I attempt to push inward. Good. Ask the client if there are any sensations of neurological symptoms such as pins and needles or sharp shooting pain down the lower leg during that contraction, which would indicate nerve root involvement. Sacroiliac joint pathology can result from joint misalignment, ligament sprain, or other soft tissue problems. With the tight webbing of ligamentous tissues, there is little motion at the sacroiliac joint, making it difficult to evaluate dysfunction. Using a series of tests and combining the findings increases your ability to confirm joint pathology and, to a degree, the specific tissues involved. The gapping or distraction test is one of 4 special tests that evaluates dysfunction at the sacroiliac joint. The gapping test places compressive stress on the sacroiliac joint region and will likely reproduce the client's pain if there's a joint alignment problem. Each hand is going to be placed on the ASIS on each side. Note when you put pressure on the ASIS, It's best to place the ASIS right in the center of your palm instead of placing it right at the base of your palm where it can be uncomfortable. With your hands located in that position, apply a moderate force in a downward and outward direction so that the hands are pushing this fashion, down and out. Just a moderate amount of pressure applied, and ask the client if there is any reproduction of symptoms that will be felt in the sacroiliac joint region. The compression test is another procedure that places compressive stress on the sacroiliac joint to evaluate the client's symptoms, particularly if it reproduces the pain they've been feeling. Simply place your palms on the lateral side of the iliac crest and apply a moderate pressure straight down on the side of the iliac crest. This pressure that you're applying compresses the SI joint on the posterior aspect. If this reproduces the pain the client's been experiencing, there is a good chance of sacroiliac joint pathology. During normal pelvic motion, the two halves of the pelvis must be able to move independently of each other. The Gansland's test pulls each sacroiliac joint in opposing directions, placing stress on the SI joint. If there is biomechanical dysfunction at the joint, this test may reproduce the symptoms. With the client in a side-lying position, the hip and thigh of the side that's lying closest to the table is in a flexed position. Place one hand on the hip and pelvis to hold and stabilize it, and bring the leg into extension on the opposite side. If this position reproduces the pain that the client's been experiencing in the sacroiliac region, there's a good chance of sacroiliac joint pathology. If the pain or dysfunction is more on one side than the other, usually the side that is the upper side when you're performing this test will be more symptomatic. So test both sides for comparison. The Faber test assesses sacroiliac joint dysfunction as well as hip joint disorders. The test gets its name from the final position of the hip at the end of the test, which is flexion, abduction, and external rotation. The Faber test applies tensile or pulling stress across the anterior sacroiliac ligaments, and it compresses the joint as well. This test also stresses the joint capsule on the side that has the hip flexed, which may reveal capsular pathology. To begin the procedure, bring the client's hip into a position of flexion, abduction, and external rotation. The foot can be placed on the anterior thigh, or if this feels uncomfortable for the client, it can also be placed on the inside of the thigh. Once in this position, use this hand to hold and stabilize the thigh in this position, and the opposite hand to press down on the ASIS so that that's right in the middle of the palm, and give a moderate amount of pressure down while this hand that's on the knee holds and stabilizes this position. If there's any reproduction of symptoms in the sacroiliac joint region, this may indicate sacroiliac joint pathology. If there's pain felt in the hip region on this side that's bent, it may indicate a problem in the hip joint capsule. As a result of its fascial connections, the gluteus maximus can be implicated in numerous problems in the pelvic, lumbar, or even upper extremity regions. This thick, large muscle has fascial connections with the sacrotuberous ligament, which also connects to fibers of the hamstring tendons. In addition, there are fascial continuities with the gluteus maximus and the opposite side lumbodorsal fascia and latissimus dorsi. Sweeping cross-fiber applications help spread and broaden the individual muscle fibers of the gluteus maximus, keeping in mind its primary fiber direction is across this way. You can spread and broaden them with your thumb sweeping over towards the other fingers. Reducing tension on the gluteus maximus through this sweeping cross-fiber application helps prepare it for work on the other deeper hip rotator muscles such as the piriformis. The sweeping cross fiber application can be performed moving this way or with the other hand moving back in the opposite direction as well. Once you have performed superficial cross-fiber applications to begin reducing tension in the muscle, you can enhance its elongation with deep stripping techniques. Begin the deep stripping techniques with a broad contact surface, such as the back side of the fist. Again, you want that deep stripping technique to go in the primary fiber direction with the gluteus maximus. Because you're using a moderately deep amount of pressure, you want to go slow with this stroke as well. And communicate with your client continually about the pressure level to make sure it is an appropriate pressure level. Keep in mind, many people have a great deal of tension in the gluteal muscles, so it's important to work slow and along with their appropriate pressure level. Once you've applied this with a broad contact surface, you can then begin to do it with a more specific contact surface, such as with the thumbs. Turning the hands around so that the thumbs are aiming and moving back towards you, and apply short, successive stripping techniques to the gluteus maximus over towards its attachment sites. Piriformis tightness is involved in a number of soft tissue disorders, such as sacroiliac joint dysfunction. You can locate the piriformis by relevant anatomical landmarks. Find the upper and lower margins of the sacrum. Locate a point about halfway between those two landmarks. Connect that point on the sacrum with the greater trochanter, and you have the location for the piriformis deep under the gluteus maximus. Again, noting the location of the piriformis as going between the midpoint of the sacrum and over to the greater trochanter of the femur. So this is the primary direction of its fibers. Our deep stripping techniques will be done with a specific application with a small contact surface, such as the thumb, and will work directly through the gluteus maximus, specifically on the piriformis, working from one end of its attachment to the other. If in the process of the stripping techniques you reproduce for the client any neurological sensations in the area or down the lower extremity, make sure not to keep pressure on that area as you might be compressing the sciatic nerve. Working on the piriformis is best done after relaxing the superficial gluteus maximus that you're working through. These deep stripping techniques on the piriformis can be done from a proximal to distal direction or also from a distal to proximal direction. The piriformis is a deep muscle, so treating it without putting a great deal of pressure in the gluteal region can be challenging. This pin and stretch technique effectively addresses the piriformis without placing additional pressure in the region. Begin by rotating the client's thigh into lateral rotation, which shortens the piriformis muscle. Once it's in that position, apply pressure with a thumb, fingertip, or other small contact surface directly on the piriformis, and slowly pull and stretch the piriformis by medially rotating the thigh. You can come back to the starting position and get a slightly different location for your pressure directly on the piriformis once again, and repeat the procedure. Once pressure is applied, then slowly pull the piriformis into an elongated position by medially rotating the thigh. If at any point this reproduces neurological sensations either in the region or down the lower extremity, you need to move to another location as you might be pressing on the sciatic nerve. Stripping techniques during active engagement are particularly helpful for treating a deep muscle like the piriformis. To perform active engagement lengthening to the piriformis correctly, you need to understand the concentric and eccentric actions of the piriformis muscle. When the client is prone, the piriformis laterally rotates the hip in its concentric contraction. During its eccentric action, the hip is medially rotated. This technique can feel intense for the client, so be sure to keep in close communication with the client about appropriate pressure levels. Begin with the piriformis in a shortened position and instruct the client to hold the position and not let you move it so the piriformis is engaged in a contraction. So Barbara, hold your leg here and don't let me move it. You will attempt to pull the lower leg towards you, engaging the piriformis's action. Apply pressure directly to the piriformis with one thumb or a finger or a pressure tool or knuckle, and then instruct the client to slowly let that go. And as they slowly let that go, you perform a short stripping technique directly on the piriformis. Now they're still engaged in a contraction the whole way during that movement, they're just slowly letting it go. Longitudinal stripping is beneficial for the disto-lumbo-dorsal fascia and the distal connections of the lumbar extensor muscles. Tension in these fibers can affect mechanics in the pelvic and lumbar regions. The fascia from the distal end of the erector spinae and multifidus blends with the posterior sacroiliac ligament complex. These fascial connections create a complex web of interconnected tension patterns throughout the lumbar and pelvic regions. The deep stripping technique is performed with a small contact surface such as a thumb or a fingertip, directly on the distal lumbo-dorsal fascia. Apply longitudinal stripping techniques along that fascial tissue and continually communicate with your client to determine if that pressure level is appropriate, keeping in mind that the tubercles that project from the sacrum are directly underneath where you're pressing, so don't use too much pressure as you're performing this stripping technique. Short back and forth friction applied over those tissues can also be effective for encouraging tissue elongation in that distal fascial. The hip abductors, such as the gluteus medius, can house myofascial trigger points or chronic tension and are important to address in many hip and pelvis complaints. The gluteus maximus and the tensor fascia lata generate significant tension on the iliotibial band, so they can be involved in both hip and knee complaints. Static compression is effective for deactivating trigger points and preparing the muscle for deeper, more specific work. You can begin by applying static compression with a broad contact surface, such as the back side of the fist or the heel of the hand. And then more specific contact surface, such as the thumb or a fingertip, directly on the hip abductor muscles. As you're applying static compression, look for locations that produce the greatest amount of tension or the greatest amount of pain that your client experiences, and that's likely where the myofascial trigger points or chronic tension are located. Simply hold that for about 8 to 10 seconds or until the discomfort subsides, indicating the muscle has relaxed a bit. Broadening techniques reduce adhesions that may develop between adjacent muscle fibers. Due to their depth, the hip abductors and tensor fascia lata require specific and targeted treatment for effective results. For the broadening technique, take the two thumbs and simply move them in opposite directions to help encourage broadening of the hip abductors. So the broadening technique moves perpendicular to that primary fiber direction. This broadening technique could be done with the thumbs or fingers or any other specific contact surface. Could also be done with the thumbs moving away from each other instead of towards each other. The gluteus medius, gluteus minimus, and tensor fascia lata frequently contain myofascial trigger points. These trigger points can mimic sciatic nerve dysfunction. Deep stripping techniques help neutralize those trigger points and encourage full tissue elongation. For the deep stripping technique, use a small contact surface because the area that you're working in is not very large. Apply slow, steady, deep stripping techniques along and parallel to the fiber direction of the hip abductor muscles from the edge of the iliac crest down to the greater trochanter of the femur. Check in with your client as you do this technique and ask if the pressure level is appropriate or if there are any areas where there's particular tenderness within those tissues. On any areas that are particularly tender, you can go back and repeat the stripping techniques a number of times directly over that site. Pain referral patterns from trigger points in the gluteus minimus can mimic sciatic nerve pain. This muscle can be difficult to access without putting an uncomfortable amount of pressure on superficial tissues. Compression with active engagement intensifies the effect of your pressure because the muscle is contracted during the technique. Simply apply pressure to the hip abductors with a small contact surface such as the thumbs or even an elbow. Once pressure is applied, have the client engage in a concentric contraction abducting the thigh. The client holds that position briefly while you maintain pressure, and then the leg is brought back to the neutral position. Again, place the thumbs or contact surface in a position, have the client abduct the leg, hold it briefly, and then it is slowly brought back down. Applying pressure to a muscle during eccentric contraction encourages further lengthening of that muscle. In this technique, the muscle is pinned in a shortened position as the client performs an eccentric lengthening of that muscle. So here we bring the hip into an abducted position to shorten the hip abductors, and from this position, apply pressure directly on the hip abductor muscles, and then instruct the client to slowly lower the leg so that an eccentric action is occurring in the muscles. The client will lower their leg as far as possible, dropping down below the table through the full range of motion into adduction. This gets the greatest amount of lengthening in those hip abductor muscles. Let's look at that once again. Apply pressure with the leg in an abducted position. Maintain the pressure while the client slowly lowers the leg in an eccentric action to help encourage tissue lengthening. Another variation of this technique could be performed where stripping techniques are performed on the hip abductor muscles instead of just static compression.